Ladies and gentlemen, it's my pleasure to introduce you to the 7 Ds of fluid therapy. These are my conflicts of interest. My biggest bias for this talk is being the co-founder of the International Fluid Academy Days. I've been very fortunate to have met Mathilde, Her Majesty, Queen of the Belgians, as well as King Philip and Maggie de Blok, the Belgian Minister of Healthcare during the past COVID crisis. My talk will be about breaking bad habits. And the following slides I adapted from my good friend Ross Fisher, who is an expert in presentations. So I would like to take you into the matrix. And the matrix is real. And our current understanding of fluids is part of the matrix. It is in fact a virtual reality. So Morpheus offers Neo a choice in the matrix to reconsider his life. So I will show you one single phrase to get you out of this virtual reality. Fluids are not innocent bags of water. Fluids should be treated as drugs. This is the matrix. And this is the basis of our current understanding on fluids and fluid therapy in the critically ill. So Morpheus offers Neo a choice. He can take the blue pill and continue believing that the world is as you see it, or he can take the red pill and reload. And that is exactly what we are going to do during this lecture. I will explain you why fluids are drugs. With the first D is about definitions. Then comes diagnosis. D3 is about the drug. D4 is about the dose. D5 is duration of treatment. D6, de-escalation when possible. And D7, when we are discharging the patient. So this 7 Ds add up, multiplicated to D to the 7th force. And this is fluid stewardship. So let's kick off with the first D. So it's not about what, it's about so what, or does the definitions around fluid therapy. And this is extremely important for you, the audience, so that we speak all the same language. And it's not my will to overload you with data, but just some key definitions are important. We all know fluid balance, which is either daily fluid balance or the cumulative fluid balance of all the intakes minus the outputs. No data overload, but fluid overload is the risk for our patients. You can calculate this by dividing the cumulative fluid balance in liters by the patient's baseline body weight, multiplying by 100% defines the percentage of fluid accumulation. So fluid overload is defined by a cutoff value of 10% of fluid accumulation. And we know that this is associated with worse outcomes. Early adequate goal-directed fluid management. This is what is referred to in the Surviving Sepsis campaign. It's on average 30 mL per kilo started within the first 1 to 3 hours. More important may be late conservative fluid management, which is defined as 2 consecutive days of negative fluid balance within the first week of ICU stay. And then even more important may be late goal-directed fluid removal, which is active fluid removal by means of diuretics or renal replacement therapy with ultrafiltration. And this is what we refer to as de-escalation, or better, actively, de-resuscitation. So while fluid overload usually is associated with hypervolemia or also hyperhydration, this will result in edema, peripheral edema or edema of the end organs. While fluid overload and hypervolemia almost always lead to edema, edema per se does not always mean hypervolemia. And that's the reason why some colleagues like Jean-Louis Vincent pointed out that maybe we should avoid the term fluid overload. So in this first D with all the definitions, and I'm not going into detail, but there are a lot of definitions that need to be given when we are talking about fluid therapy or fluid stewardship. It would bring me too far to explain all these definitions right away, but during the talk, I will allude to some of them when necessary. So let's move on to the second D. It is not about the what, but the diagnosis, which is extremely important. The fluid state. Hypovolemia is bad. The application of what we already know will have a bigger impact than any drug or technology likely to be introduced in the next decade. And I would like to add on this, any drug, technology, or fluid. So we are used to make existing drugs better. I think we need to make good drugs better, and we need to make good fluids better by giving them for the right indication at the right dose for the right duration. When it comes to antibiotics, we're all familiar with antibiotic stewardship. And studies have shown that in about 30% of patients, antibiotics are given longer than necessary, there was no infection, or were given for colonization. So maybe in the near future, if we would do research on the use of fluids, I guess that in about 1 in 2 patients, fluids will be given inappropriately, and this may lead to adverse outcomes. While hypovolemia is not good for the patient, hypervolemia is even bad, as we need to balance between hypovolemia and convective problems to hypervolemia, avoiding diffusion problems, all related to interstitial edema and difficult wound healing, difficult oxygenation, also increased intra-abdominal pressure. So, as stated, the fluid status of the patient matters. And there are a lot of myths going on with regard to fluid therapy. One of them may be that septic patients are always hypovolemic, and this may not be the case. Likewise, surgical patients are also not always hypovolemic. Septic patients do not always have large insensible losses. Peripheral edema does not always mean that we should give diuretics, nor does a low preload mean that we should give fluids, as we also need to know whether or not a patient is fluid responsive. But first, we need to understand what is the preload. The preload is in fact the initial stretch on the actin-myosin complexes, while in reality we have a combination of preload and afterload. So ideally, preload should be measured as left ventricular and diastolic volume, but at the bedside this is cumbersome, while afterload is the left ventricular and systolic wall stress. So this is the theoretical concept, but practically and ideally, preload should be a combination of parameters that tell me as a clinician if fluids are needed and can be given safely. whether also they will have an effect on blood pressure, cardiac output, and organ perfusion. So whenever there is a therapeutic dilemma, which means that either fluid administration or fluid removal can have a detrimental effect on patient condition or organ function, we should think beyond cardiac output and always balance the benefits of fluids administration versus the risks. So for that, we need to assess the preload, and preload can either be assessed barometrically, like traditional central venous pressure, or with modern techniques, volumetrically, like a global endostolic volume. But we also need to assess fluid responsiveness with functional hemodynamics, like pulse pressure variation, but also fluid responsiveness tests, like the passive leg raising test or the end expiratory occlusion test. And when it comes to the risks of fluid administration, we must monitor the impact of potential fluid overload on organ function. And for that, we can look at extravascular lung water, PF ratio, pulmonary vascular permeability index, or maybe cardiac ultrasound. And we must also be aware that other factors like intra-abdominal pressure or increased intrathoracic pressure related to positive pressure ventilation of the application of PEEP can have an impact on these parameters. Fluid status matters. So what are the clinical signs of hypovolemia? Well, there are numerous clinical signs when it comes to each and every organ function that can indicate that the circulating blood volume is low. I'm not going into detail, but clinical signs are usually aspecific. What are the other signs? The other signs refer to either laboratory signs, imaging, ultrasound, like I already mentioned, hemodynamic monitoring, or the impact of hypovolemia on organ function. So laboratory signs are very interesting. They can either be increased lactate, or they can refer to hemoconcentration, like increased in protein, sodium, or even hemoglobin parameters. Urine electrolytes, I believe in the future, will become very important, especially if we are able to monitor these parameters in a continuous and automated way. Already mentioned the hemodynamic parameters of hypovolemia, either barometric, volumetric, and fluid responsiveness. Also, when we look to the chest X-ray, there may be some signs of hypovolemia, and the impact on end organ function may also be related to hypovolemia. Bioelectrical impedance analysis, I will refer to this later, may be very promising and non-invasive tool in the future. Fluid status matters. For this, we need to know some other definitions. Osmosis is the movement of water across a semi-permeable membrane, while osmolality is the number of osmoles per solute per kilogram of solvent. So the serum osmolality can be calculated as seen below, whereas the tonicity is referred to as the effective osmolality, and it's just basically by the sodium content in the serum. Tonicity is not the same as osmolality. While tonicity of a fluid will determine the distribution, and the osmolality will determine the tolerability when we're infusing it. For that, we need to make a difference between the effective osmoles, usually the sodium, whereas from the others, it's more unclear. And this also defines why different fluids and balanced solutions may have differences in osmolality versus tonicity. So when we go back to body composition, we all know that the human body is almost 2/3 consists of water, and the total body water is the sum of the extracellular water and the intracellular water. So assuming that 2/3 of our body consists of water, about 2/3 of this water is intracellular water and 1/3 is extracellular water, out of which about 1/4 is the intravascular fluid and 3/4 is the interstitial fluid. So if we would then infuse 1 liter of saline, this crystallate would go to the extracellular compartment, and after 1 hour would be around 250 ml in the intravascular compartment, and the rest would be interstitial. If we would infuse a hypertonic solution, like for instance 1 liter of dextrose, 5%, because of this hypotonicity, the fluid will also go intracellularly, about 2/3. And at the end, after 1 hour, about 83 ml will remain intravascularly, and the rest interstitially. If you would give a hypertonic solution, like for instance 1 liter of 3% saline, because of the hypertonicity, we assume that some fluids may be attracted from the intracellular water, so that the intravascular effect may even be a little bit after 1 hour. And administration of colloids, at least in the first hours, we assume that this volume will remain completely intravascularly. So if you want to see the effect of fluids on volume expansion, for instance, after 1 hour, about 10% of glucose will remain intravascularly. For a crystalloid, saline or balanced, it's about 25%, and a colloid, put a question mark there, we assume it's about 100%. Meaning that hypertonic solutions are probably not a good choice for resuscitation. So body composition can be assessed by bioelectrical impedance analysis, which is a simple device that sends currents at different frequency throughout the body. And when there is fat tissue, this acts as an insulator, whereas muscles and water act as a conductor, and there the electric current will easily pass through. So by measuring this conductive tissue and insulation tissue, or the conductance and resistance, we can calculate the bioimpedance. And this relates to total body water. We can separate extracellular water, intracellular water, and with the latest algorithms, you can also identify the intravascular and the extravascular fluid in your patient. Fluid overload is always associated with low impedance. Brings me to the next D. Fluids are not just an innocent bag of water, but they should be considered as a drug. And we need to ask ourselves different questions. But of course, first thing is not to harm the patient. So what are these 4 questions? First question is when to start IV fluids. Second question being when to stop fluids when they are no longer needed. Third question, when to start fluid removal if there is some form of fluid accumulation. And when we are actively removing the fluids at some point, you must ask yourself when to stop fluid removal to avoid hypoperfusion. Other questions we need to ask is what is the indication for giving a fluid to our patient? And there are only 4 indications. First is resuscitation fluid, and this should save lives. Thing is that these fluids received most attention in the literature. And we all remember the Vrije study, the River study, the Christmas, Crystal, Chest 6S, SMART, SALT, relief trials, split trial. These studies are about resuscitation fluids. All the results of these big fluid trials create a lot of reaction. Was like an earthquake or volcano or tsunami of reactions, and you even had pros and cons, people believing that colloids should be the first choice, whereas others believe that crystalloids. But I think that the evidence now is clear that when it comes to surgery and trauma, we could still use starches, but I would not advocate to do so. There is no data on gelatins. Saline in large amounts is not a good idea. That's why in burns, where people are getting a lot of fluids, only balanced crystalloids are used. And as stated, hypotonic solutions are no good either. So I think in surgery and trauma, balanced crystalloids are a good first choice. Of course, blood when the patient is bleeding, taking into account shelf life, and fluid strategy being important. So what about septic patients and ICU patients? I think it's the same there. Balanced solutions are a good first choice. And maybe we'll see about the next Albios trial, there may be a place for hypertonic albumin solution later on, either in combination with diuretics for de-resuscitation. But again, the fluid strategy is more important than the fluid per se. So while resuscitation fluids received most attention, the largest part of fluids that are given to a patient are other type. And this became clear in this nice study by Niels van Regenmortel, about 15,000 patients, about 100,000 patient days, where they looked at all fluids administered. The results are very interesting because only 6% of the fluids were given for resuscitation, 25% were maintenance, 33% was for nutrition, and the rest, 1/3 was fluid creep. Fluid that seeped into the patient for administration of painkillers, antibiotics, and other medication. So resuscitation, most attention to save lives. Maintenance fluids, they should just cover the daily needs when the patient cannot take anything per mouth. And the daily needs for water, sodium, potassium, glucose. So for water, it's about 1 ml per kilo per hour, 25 ml per kilo per day. Sodium, potassium is about 1 milli equivalent kilo per day, and glucose 1 to 1.5 grams per kilo per day. There is not much data on maintenance solution, and that's why Niels van Regenmortel performed this study in fasting elder volunteers, so 2 days. They only received maintenance solution, and in the study was compared the isotonic fluid with saline 0.9 and a hypertonic ready from the self maintenance solution. As you can see here, urine output is greater when hypotonic solutions are given, and fluid balance was less positive when hypotonic solutions were given. This was then followed up, recently published in Intensive Care Med, the TOPMAS trial, comparing hypotonic and hypertonic and isotonic maintenance solutions in critically ill patients. Follow-up was 3 days. And again, you see that the fluid balance was about 1.5 liter less positive in the patients receiving hypotonic solutions. So again, pointing towards the benefit, not for saline, but for hypertonic solutions. And this is probably the reason when you're in Belgium having a Belgian beer, you always get some peanuts, salted peanuts, beer being hypotonic. When you give the peanuts, you make it more isotonic probably, so it makes you more thirsty, you drink more, and you go less to the loo. So it's a win-win. Third category, replacement fluids. Well, they should mimic the fluid that is lost, and gastrointestinal losses are probably the only indication for what I would call abnormal saline, because you and I, we don't have 154 millimoles per liter of chloride in our blood. And often overlooked, but it's also a source of fluid accumulation, as nutrition fluids, and they should cover the daily caloric needs of the patient. Best way is enteral route when the guts are working. So the third is fluids are drugs. Brings me to the concept of the 4 Ds in analogy to antibiotic stewardship, where we very well know that antibiotics should be treated as drugs, of course, and we refer to as the 4D. So it's the drug, the dose, duration, and the escalation. So the first D being fluids or drugs. So the type of fluids is important. The treatment should, of course, be appropriate. We could go for combination therapy, and the timing also must be appropriate. So it's completely in analogy to antibiotics, because we know that there will be more organ failure and longer ICU and hospital length of stay, even ventilation, if antibiotics are given inadequately. And we also know that for the empiric therapy, it's important to take into account patient risk factors for MDR. So when we compare antibiotics on one side and IV fluids on the other side, when it comes to inappropriate therapy, for antibiotics, we know that there will be more organ failure, ICU hospital length of stay, ventilation. And for IV fluids, we also know that giving inappropriate treatment will or may lead to hyperchloremia, metabolic acidosis, AKI, increased incidence of renal replacement therapy, and mortality. So whereas appropriate therapy, when it comes to antibiotics, when we start empiric therapy, we take into account prior use of antibiotics, if the patient is ventilated, if the patient has received corticosteroids or previous. So for fluids, we should also take into account kidney function, presence of capillary leak, source control, what is the fluid balance, what is the body weight, is there fluid accumulation, and so forth. When it comes to combination therapy, for antibiotics, the idea is to combine two antibiotics to have a broader spectrum, some synergy, less resistance, but the drawback may be more toxicity. For fluids, it depends. There are specific fluids for different indications. And by giving the right fluids, I believe that we may give less fluids and have less toxicity. So while for antibiotics, it's a pragmatic approach, and empirically you should say, yes, we will combine. But for definite therapy, we should not combine and de-escalate as soon as possible. Whilst for fluids, we do it all the time. For resuscitation fluids and trauma, we will combine blood products and crystalloids. And sepsis, maybe crystalloids early, albumin later. And perioperative, we still may use starches and some crystalloids. Maintenance, probably combination of antral and parenteral fluids with some crystalloids to administer drugs and so forth. When we look at appropriate timing, which is very important for antibiotics, we know that each hour delay will increase death rate with about 7%. For fluids, initially, there were some data that early goal-directed therapy is beneficial, and the longer you delay, the worse the outcome. But I think also the longer the delay, this may cause microcirculatory hypoperfusion that may increase. So in this study by Kumar, you can see that if you look at the time from hypotension in patients with septic shock, that per hour delay, there is an increase in mortality with about 7.6%. So likewise for fluids, we may need to think in limiting fluids. And there's a very interesting, albeit retrospective study by Murphy, looking at early adequate fluid therapy and late conservative. Late conservative is 2 negative fluid balances consecutively in the first week. And you can see that if you give little fluids initially and be conservative later on, your prognosis is much better than if you give too much fluid initially and keep on giving too much fluids later on. So constrictive strategy may be important. Brings me to the 4D. So it's not about the what, but it's about the dose of the drug. So how much fluids are we going to give? Likewise, like we do for antibiotics. You have to refer to Paracelsus, who stated, alle Dinge sind Gift und nichts ohne Gift. Allein die Dosis macht, dass ein Ding kein Gift ist. So all things are poison, nothing is without poison. And it's the dose that permits something not to be poisonous. So key concept is the dosing of antibiotics, and it's referring to therapeutic drug monitoring. Where we talk about pharmacokinetics is what becomes of the drug when it's in the human body. So it's about the distribution volume, the clearance. And the pharmacodynamics is the action of the drug on the bug. So if we again would compare antibiotics on one hand and fluids on the other hand when it comes to pharmacokinetics, so for antibiotics is distribution volume, the clearance, whether they're cleared by kidney or liver. Albumin levels do play a role, tissue penetration. And for fluids, again, depends on the type of fluid, distribution volume important. As I told you about osmolality and tonicity of the fluids and kidney function, also heart failure may play a role. So what is the effect of infusing a fluid on blood volume? Well, as long as the infusion is ongoing, blood volume is expanded with about 50 to 100%. And the reason for this is slow distribution. So crystalloids may be as effective as colloids as long as they are infused. So next comes the distribution. And here we see that if the arterial blood pressure decreases, that crystalloid distribution almost stops. So 100% of the infused fluid then remains in the blood. The reason for this is the storing mechanism. And this means that in a shock state, you could have the same volume expansion effect by administering crystalloids as compared to colloids. And this is from interesting data from Robert Hahn. Likewise, the excretion of a crystalloid is very slow during anesthesia surgery or when blood pressure drops, as you can see here, compared to conscious volunteer. So blood volume expansion is maintained in those situations. The reason for this is mainly unknown. Again, looking at antibiotics versus fluids when it comes to pharmacodynamics. For antibiotics, we have these definitions of minimal inhibitory concentration, the kill characteristics, time above MIC, and then the peak MIC ratios. And we know that for aminoglycosides, they are concentration dependent. Fluoroquinolones, it's the area under the curve above the MIC. And for beta-lactams, it's the time above the MIC that is important for the kill characteristics. So for the fluids, again, it depends on the type of fluid. Where do you want the fluid to go? If the patient is dehydrated, if there is cellular dehydration, then you may give hypertonic solutions. For resuscitation, of course, intravenous. But as stated, for cellular dehydration, you may want the fluid to go interstitially or intracellularly. So traditional doses for maintenance, about 1 ml per kilo per hour. Resuscitation, already mentioned 30 ml per kilo. And a fluid bolus of 4 ml per kilo in 15 minutes may be a good choice for small volume resuscitation. Be aware that replacement fluids may cause fluid creep, and also be aware that the timing is important and the speed of which you administer the fluid. Remember again that about only 6% is resuscitation, 25% maintenance, 33% nutrition, and 1/3 is fluid creep. Think about it. When it comes to assessing the response to IV fluids, so to know when to stop, there are traditional static surrogate parameters like CVP, blood pressure, urine output. You can also look at dynamic functional parameters or the passive leg raise test. I've told you that static parameters are no good to determine when to start or when to stop fluids. When it comes to pharmacodynamics, likewise for antibiotics, for fluids, there probably will also be effective dose, toxic dose, or even a lethal dose has been published by giving too much hypotonic solutions. The patient was dying. Again, comparing antibiotics and fluids when it comes to toxicity, we know that some antibiotics are toxic for the kidneys, so we need to adjust the dose, but not getting infection under control isn't helping the kidney either. Likewise, some fluids are toxic for the kidneys. However, not getting shock under control is not helping the kidneys either. For starters, we know the maximum dose is about 30 ml per kilo per day. Brings me to the fifth D, again, not about the what, but it's the duration of the therapy. And what I in fact really want to know is, of course, when do I start giving fluids, when do I stop? So it's all about the benefit of fluid administration versus the risk of fluid administration. Again, comparing antibiotics and fluids, the duration needs to be appropriate. For antibiotics, there is no strong evidence, but now there's a trend towards shorter duration. And we don't treat fever, we don't treat CRP, but we treat infection. So literature points towards shorter and shorter duration of antibiotic courses. Also for fluids, I don't think we should use them to treat a low CVP, a low pressure or urine output, but we need to use fluids when they are indicated to treat shock. We stop when signs and symptoms of infection are resolved. Maybe there's some roles for biomarkers in the future. Likewise, fluids should be stopped when shock is resolved, and there may be a role for future biomarkers. Brings me to the next D, which is about de-escalation of fluid therapy. Because the third question is, when do I start unloading or fluid removal? So it's about the benefits of fluid removal. And the last question is, when do I stop unloading? So the risks of fluid removal, which may be hypoperfusion. For antibiotics, we know that de-escalation is the key, is the gold standard, because we think to reduce selection pressure for resistance. But studies show that only in about 40% de-escalation is actively performed. So we need to have the guts to change a winning team. Monitoring is important. So for fluids, I think after stabilization, when parameters normalize, we should stop early adequate goal-directed fluid management. Then we should aim for late conservative fluid management, and even in some patients with fluid accumulation, fluid overload, we should resuscitate. Brings me to another concept, which is the 4 phases. And about the same time in 2014, 2 papers were published discussing these dynamic phases of fluid therapy. One advocating the acronym SOSD, and we suggested ROSE. And if you would ask Twitter, then the majority would prefer ROSE, as it's much more easy to pronounce. So what is this ROSE? It's like the blossoming of a flower, the rose, when you give fluids. So you resuscitate the patient, you optimize organ function, organ support, you stabilize the patient, and then comes de-escalation, followed by de-resuscitation, evacuation, hence the acronym, the ROSE. So when you have time on the x-axis and the fluid balance or the volume status on the y-axis, after the first hit, whether it's sepsis, surgery, trauma, burns, fluids, or life-saving, fluid balance must be positive, resuscitation. Then comes organ support. So the second hit being ischemia reperfusion. You need to go for maintenance, homeostasis, and then stabilize the patient and preserve organ function. Normally, the patient will evacuate the excess fluids himself, but some patients may end the third hit, which is global increased permeability syndrome, and may need active fluid removal or deresuscitation. And of course, when you're removing the fluids, we must avoid the negative fluid balance, hypoperfusion. So hence the acronym ROSE. And I just have to tell you that the rose at the end, it's a dry rose. It's not a dead patient. And I'm very happy to see that this concept, this rose concept, has been picked up by other colleagues, for instance, in this paper in neurocritical care. But if you look at the literature, the current literature, I mentioned all the big fluid trials. If you put them on the x-axis, you can see that some studies were really early in the process, whereas most of the big fluid trials like success and chest took place after 24 hours. So after the initial resuscitation phase taking place, and already with the same amount of drug fluid that had been given prior to randomization. So it's very difficult to compare this data. So initially, we have to give fluids, goal-directed therapy, rescue the patient, optimize organ function with late conservative fluid management, stabilize organ function in the patient, and then maybe in some cases, late goal-directed fluid removal to evacuate the excess of fluids to save the patient. And we may look at different targets and endpoints, parameters, which may be functional hemodynamics initially, which may be related to normalization, to go for late conservative fluid management. And when fluid overload related to the global increased permeability syndrome has an impact on end-organ function with a drop in PF ratio, an increase in lung water, abdominal pressure, then we may need to evacuate. And whilst evacuating, maybe we need to look at other parameters for perfusion, like central venous saturation or ICG-PDR. But there is not much data for that. So this is a big question mark because there is no single study taking into account all these different phases and guiding the patient through them. But I think the most important goal of fluid therapy is to avoid fluid overload, fluid accumulation, and the global increased permeability syndrome. The reason for this is that I believe that anasarca, peripheral edema, fluid accumulation, is not cosmetic. Why not? Because a positive fluid balance is an independent prognostic factor in patients with sepsis. You can see that if you have a restrictive regimen, that outcome is much better. Mortality is lower compared to patients with liberal fluid management. The other reason is that fluid overload at the outside is related to fluid overload at the inside. So there will be end-organ fluid accumulation, venous congestion. There's a lot of talking about the VEXUS score to look at the impact of fluid overload on venous circulation, but nearly every organ will suffer. And eventually, this will end up to global increased permeability syndrome. So late conservative fluid therapy is the way to go. And there is some evidence already. So if you would compare the different studies, then you can see that early conservative, late conservative group carries the best prognosis. So when should you think of active fluid removal? So I would say if the patient is not transgressing spontaneously from the ebb to the flow phase, is not evacuating the excess of fluids himself, and is remaining in this persistent state of global increased permeability syndrome, then we should give the patient a little help. So this GIPS is a persistent positive cumulative fluid balance plus organ failure. So it's adverse effects of fluid overload. Mainly it's pulmonary or also related to abdominal hypertension. So how then to guide the resuscitation? So there's a question how to assess hypervolemia, but how to guide the resuscitation. I think again here clinical assessment is useful but is specific. You could look at biochemical assessment of fluid overload. So here it's hemodilution or ongoing infection, poor source control, and so forth. There are some radiological signs of fluid overload, obviously. Hemodynamic assessment of fluid overload, like the absence of fluid responsiveness, for instance. And organ function assessment of fluid overload with transpulmonary dilution, liver perfusion, again, abdominal pressure, maybe some biomarkers that could be indicative. And in the future, maybe there will be some other new Vrije techniques that may help us to guide the patient through the de-resuscitation phase. And I think blood volume measurement, like with the DAXA, which is technetium-marked albumin dilution, but more easy, I think, bioelectrical impedance analysis or electrical impedance tomography can be very helpful. Brings me to the last D, which is discharge of the patient. So when the patient survives ICU, what can you do then when it comes to fluid management in your hospital? The question, these are some slides from Marshall McDougall. Is there a problem with fluids? What should we be doing? What about guidelines? And how can you demonstrate the impact? So there is definitely a problem. We should go for fluid stewardship. Most of the guidelines, they are not personalized, individualized. I will tell you a little bit how they dealt with it in Northampton and our experience in Brussels and the key performance indicators that you could use. So in Northampton, some slides of my good friend Johnny Wilkinson, they checked fluid prescription habits, and the results were devastating. So patients were either dehydrated or fluid overloaded and on CVH or fluid overload or AKI due to hypovolemia. Then they had a knowledge questionnaire referring to a male patient of 70 kilos, and about the scores were 8 to 40%. So this was not good. Then they had some questions on composition of fluids used currently in their unit. And again, here, the knowledge was very poor, with 0 to 40%. So in Northampton, they were sacked, and you could say it about fake news. It just happens in Northampton. But they did not consider that to be fake news. They launched a three-pronged attack for IV fluid safety with education, changing the practice and increasing the awareness. Moreover, they performed a clinical audit of twice 60 cases. There were some medical cases where they found that the sodium daily needs were excessively given, so 9 times too much sodium. The potassium needs, they were not reached, 60% of the goal. And in surgical patients who also received too much sodium and too little potassium. What were the prescribed maintenance fluids in Northampton? So it was mostly saline for internists and balanced solutions for surgeons. So prescribed maintenance solution was saline in 2/3 by internists and balanced solution, Hartmann solution in the surgical patients. Inappropriate fluid prescription was in 1 in 3 of medical patients and about 10% of surgical patients. Inappropriate fluid prescription was defined as a high sodium above 145 and further increasing, or low sodium and falling sodium, and then prescription of hypotonic solutions. And for potassium, you can read it there. So potassium was high and it was given extra potassium, or it was low and patients were not receiving enough. Then another test was whether there was lab and urea electrolyte testing on the same day of the fluid prescription. So likewise, similarly like you would do for antibiotics, if you would give vancomycin or aminoglycoside, you want to know kidney function. This was the case in 1 in 2 of medical patients and about 37% of surgical cases. So the clock is ticking and we are not giving appropriate fluid therapy. So I think we can do better. And we should aim for fluid stewardship. And this has been summarized in an open access paper on the 4Ds and 4 phases of fluid therapy. This paper has received a lot of attention with a very high altmetric score. So definition of fluid stewardship is a series of coordinated interventions introduced to select the optimal fluid dose and duration of therapy that results in the best clinical outcome, prevention of adverse events, and cost reduction. So the most appropriate therapy, prevention of adverse effects, and reduction in costs. For that, you need to take a snapshot of the fluid consumption, conduct a survey of doctors and nurses, and then a medical audit. So this is what we did in Brussels, and we consumed a lot of abnormal saline and also balanced solution. We had done a questionnaire on the knowledge for doctors and nurses. The average score was about 40%. And here, just an overview of some questions. For instance, what is the glucose content of plasmalyte? 75% got it right, there is no glucose. What is the sodium content of saline? So it's 154, so half got it right. Sodium content of glucion, which is ready for the shelf balance solution, it's about 50, 40% got it right. If you ask what is a good volume for a bolus, should be as low as possible, and you should assess the effects of the bolus. 1 in 4 got it right. So the average score for doctors was 30% and for nurses 50%. So we are sacked in Brussels, and I believe that if you would do the knowledge test in your hospital, you would be sacked as well. So again, we can all say that this is fake news, or we can make a change and start with fluid stewardship right now. And it's about setting the right targets in order to reach the goal, and the goal would be appropriate fluid management with on-the-floor learning following the 5 Ps of fluid prescription. So key is the identification of fluid stewards, doctors and nurses, provide them teaching, set up some posters, flyers, screensavers, and then provide feedback via plan, do, check, act cycle. So the last part briefly will be, can you demonstrate the impact of fluid stewardship? And this is how Marsha McDougall did it in 5 in Scotland. You can see that when they implemented the fluid charge, you can see that the average amount of fluids prescribed increased. But over the years, you can see that with the implementation of fluid stewardship, fluid nurse charge, you can see that there are more balanced solutions. This was what they chose for, and the sodium, the saline was reduced, and more hypotonic maintenance solutions. And this resulted in a reduction of liters per occupied bed day from 0.6 to 0.35, and a reduction in costs. So we looked what happened in Brussels after the implementation of fluid stewardship. So we see a drop in saline, an increase in plasmalyte, a drop in the ugly maintenance solutions, increase in the ready from the shelf. But maybe some patients do not need maintenance. And the key performance indicator may be the ratio between balance versus saline, and you see an increase here, or the ratio of ready from the shelf hypertonic solutions versus the other ones. And this is some data from last year. Data is analyzed. You can see again that the numbers of liters per stay is about 4 liters to 2.3 liters. and liters per day from 0.6 to 0.4. So it's similar results as what Marshall McDougall observed in Scotland. So ladies and gentlemen, to wrap things up, I hope I have convinced you that what you knew about fluids is a virtual reality. Fluids are not innocent bags of water, but fluids are drugs. They have indications and contraindications, potential adverse effects, and should be treated as such. So just as an overview, we need to go for personalized care. You need to identify a fluid team. And then the first D was about the definitions. So what is fluid overload? What is hypervolemia? Does edema always equal hypervolemia? And all these things. Second D is about diagnosis. How do you assess hypovolemia? The monitoring, so the clinical, laboratory, radiological, organ function. I explained to you about bioelectric impedance analysis. We may look at the 4 body compartments. Next comes the third D as drug. So fluids have indications, contraindications. So we need to ask the 4 questions: when to start and stop fluids, start and stop fluid removal. Think about the 4 indications: resuscitation, maintenance, replacement. Don't forget nutrition. Think about adverse effects. So we need to give appropriate therapy, combination therapy. Timing is important. The 4 Ds of drugs. So next to drug comes the dose. Remember the pharmacokinetics, the pharmacodynamics. Also this relates to toxicity. Duration should be appropriate and treat fluids to response, not to normalize CVP. D6 is de-escalation. I showed you the ROSE model with the 4 phases. And to evacuate or de-resuscitate, you may guide yourself by clinical, laboratory, organ function, radiological. Think about the 4 hits. And then, of course, when discharging the patient, you should take it to a holistic level for the hospital, implement fluid stewardship with a snapshot survey audit, and identify the key performance indicators, and then you have your plan, do, check, act, cycle. So I think personalized therapy is important. And this consists of doctors and nurses that will be your fluid stewards. Having said that, it's my pleasure to invite you to the first virtual International Fluid Academy Days, the end of November, and registration abstract submission is now open. I thank you for your kind attention.